Okay. Our speakers tonight, Martin Allen Auerbach, MD, is Director of Nuclear Medicine at the Westwood and Santa Monica campuses at UCLA hospitals, and Associate Professor in Nuclear Medicine, Division of Pharmacology at the David Geffen School of Medicine at UCLA. Apart from serving as attending physician in nuclear medicine at UCLA, Santa Monica, and Westwood, his research includes clinical studies investigating the role of molecular imaging with PET-CT to gain insight into malignant disease process. Dr. Auerbach has practiced for 42 years. Here's a link, and I'm gonna try to get this to chat so that you could learn more about the doctor and save the chat and learn more about him later. Dr. Calais is assistant professor at UCLA Amundsen Translational Imaging Division of the Department of Molecular and Medical Pharmacology. Dr. Calais received his MD degree from the University of Paris in 2010. His work focuses in on improving the outcomes of cancer patients by translating and applying novel diagnostic and therapeutic approaches. He uses PET imaging for cancer phenotyping, radiation therapy planning, and therapy response assessment. He leads clinical theranostics research programming at UCLA that combines radionuclide therapy and imaging. You can learn more about him here. I'm going to try to get these links up on chat so you can check it out later. We're the prostate cancer. We're at Prostate Forum of Orange County. We've been around about 27 years now. We're a 501c3 nonprofit. You can learn about us at prostateforum.org. This presentation is being recorded for future access on youtube.com. And you can visit pardon me, our YouTube channel here at, this is our YouTube link. If, pardon me, you're unable to get it, you can see our homepage and be able to get the little YouTube button in the upper right-hand corner of our homepage. We are a nonprofit. Even small donations help us a lot. You can send a check here to Prostate Forum of Orange County, 1519 East Chapman, Box 380, Fullerton, California, 92831, or by PayPal. There's a donation link on our homepage at prostateforum.org. Click on that; it'll take you to the donate. If you've not signed up for emails or for some reason aren't getting emails, give us your last name, first name, and your email here at prostateforumoc@gmail.com. We take kind of a traffic cop approach to questions, so please post your questions in the chat. You can do that at any time, and then I will ask those questions of the doctors, and then you'll have a chance to go up and back. Question and answer follows the doctor's presentations. So without further ado, Dr. Calais, Dr. Auerbach.
We'll ask you to unmute, Dr. Auerbach. It's the microphone down on the bottom.
Or hold down your space bar.
Yeah.
Boy.
There we go. No, that's Aaron. Aaron, we need to put you on mute.
Oh, I think. Sorry about that.
Gotcha.
Good evening, and thank you for having us again. Present at your renowned forum here. I hope everyone is doing all right and weathering the COVID storm, getting vaccinated and staying safe. So this talk is going to be two parts. My part is the first part, and I'll share my screen with you. Can you see the screen?
I sure can.
Yes, indeed.
That's
Thank you.
Good, good. So my part of the talk focuses on imaging, and then Dr. Calais will focus on therapy. Please, if you have any questions, just keep them until the end of the talk
Have that much
or
food?
talks, and
You're
then
eating
we'll
more
be
than
happy
me.
to
Is that
answer
what you
questions
want?
that you might have. And
that what
if you're
you
not
want?
muted, please mute yourself. Some people are still
That's funny.
unmuted. Mr. Marshall. Okay. So my talk focuses on imaging of prostate cancer and on the what, why, and when. The overview here is I will be talking about how do we image prostate cancer, and then also how does imaging help the staging of prostate cancer, selection of patients for radioligand therapy, and then also imaging for checking how effective treatment is being given for prostate cancer. So how do we image prostate cancer? Most of you have undergone various types of scanning and are familiar with these. So we have anatomical imaging that demonstrates or shows the physician who reads the scan structures. And the most common anatomical imaging is CAT scanning or CT, and then MRI and ultrasound. We also have molecular imaging, which gives us molecular information, and imaging modalities for that are SPECT and PET. And then over the last 2 decades, there has been development of what we call fused imaging, which combines both anatomical imaging and molecular imaging. And that's SPECT CT and PET CT. So how does anatomical imaging work? Anatomical imaging uses X-rays, magnetic fields, or ultrasound waves. And as I said, it images structures. So in the example here of an X-ray, which also applies to CT scans, you have a machine that produces X-rays. They're sent through the body that we want to image. And then we have detectors and the scanners that, and the software that's attached to that, and that creates an image. And the job of a radiologist or nuclear medicine physician is to read these images and write a report. Here's an example of what we call a coronal view. This is looking at the body from the front. This is from a CT scan. You can see nice structural information here. You see skeleton, spine, for example. Here you see the liver and the kidneys. And then somebody who's trained can detect abnormalities in these anatomical structures. Molecular imaging uses radioactive tracers. These tracers allow us to see what is happening inside the body at the molecular and cellular level. In the case of prostate cancers, we have tracers that target structures that are present on the prostate cancer cells. So if you imagine this is a prostate cancer cell. This is the target that we're trying to get to with our tracer. This is our tracer here. It has 2 components. One component binds to that structure that's present on the prostate cancer cells. And the other component is a radioactive isotope that emits photons that can be detected by a scanner. And then the software, together with the scanner, creates an image of that molecular information. So here are the tracers that are particular to prostate cancer. I'll start here on the right, where you have tracers that have been used in the past. They are falling by the wayside since the arrival of these tracers here. But F-choline images and C11 acetate, these image fatty acid metabolism and cell membrane synthesis. Oxumin, which is still being used, images amino acid transporters that are upregulated in prostate cancers. And then the most successful tracers that target the PSMA structure that's present on prostate cancer cells. And these are labeled with gallium-68 or F18. Some of you might have had an Oxumin scan. Some of you might have had a PSMA scan. There is data data that was collected when we started with PSMA imaging, and it clearly shows an advantage of PSMA over the Xuman scan. You can see that the detection rate with PSMA, the exception of the prostate bed, is significantly higher for all organs outside the prostate. So now that PSMA is approved, Xuman is going to fall by the wayside pretty quickly and become an obsolete tracer. Just as an aside. Now, fused imaging, as I said, combines structural and molecular or functional information. Using here SPECT-CT, PET-CT, and then some places have also PET-MRI. And here you have a PET-CT that combines the molecular information, that's what you see here in yellow, together with the structural information of the CT scan. And if I see an abnormality on the PET portion, I can localize where this abnormality is located, as in this case, a patient with prostate cancer that has a bony metastasis here in the spine. And so how does this imaging help us manage and help treat patients? So when you get diagnosed with the disease, the first thing that you need to do to decide what the appropriate treatment is, you need to stage the disease. And somebody who's already getting treatment, you need to restage the disease to see whether the treatment is working. So in this initial staging of prostate cancer is usually categorized as localized disease, where the disease is only present in the prostate. In these cases, surgery or radiation therapy can be curative. Then there is a stage that is called oligometastatic, where you have the primary disease and you have usually somewhere between 3 or 5 metastatic lesions. Oligo means few in Greek, and these patients often undergo surgery or radiation to the prostate, and then additional radiation, in rare cases also surgery, to those few metastatic lesions with the hope of curing the cancer. Now, once you have developed metastatic disease, then of course local therapy is no longer applicable. The disease is what we call systematic, and the treatment also has to be systematic. Usually with hormone therapy, estrogen deprivation therapy being the first line of treatment. So this is initial staging, determining how much disease there is, and that then determines what the treatment approaches can be. How does PSMA PET-CT imaging impact on the management of prostate cancer? This is from studies that were done with pre- and post-scan questionnaires sent out to the referring physicians, asking what their management was before they had the information from the PSMA PET-CT, and asking what their management of the patient would be after they received the results from the PSMA PET-CT. And management changes were implemented in over 2/3 of patients. So the PSMA PET-CT really had a significant impact on how patients were going to be managed. And changes in management mean that the patients received surgery or did not receive surgery, were moved away from surgery, systemic therapy, or moved to radiation therapy. So all kinds of changes occur in about 2/3 of patients. Now, imaging can also help us select patients for radioligand therapy. If you recall this cartoon here, this is imaging. We have the PSMA target that's present on the prostate cancer cell, and we have a radioactive isotope that labels our tracer, a radioactive isotope that allows us to take a picture. Now we can also label this tracer that binds to the PSMA receptor with a different radioactive isotope, in this case, lutetium-177. Lutetium-177 decays by emitting electrons. And these electrons locally bombard the tumor cells and can kill the tumor cells. So if you have a scan and you see a lot of uptake, all these dark spots are high uptake. This means there is a high density of the PSMA target present on the tumor cells. These patients are good candidates for the treatment. Unfortunately, sometimes cancers do not express that many PSMA structures on their cell surface. Then you'll see less uptake. Or in other cases, there is no PSMA present and you'll see no uptake. Obviously, these patients are not good candidates for the treatment. Now, fortunately, prostate cancer, over 90% of prostate cancers have a good expression of the PSMA target. So a lot of patients are able to qualify for the treatment. Now, when we do treatment, we also want to know how effective it is. If this is the tumor, when we talk about treatment, and now I'm talking about the lutetium PSMA treatment, it's very rare that the tumors completely disappear. Why is that? Well, once we give the PSMA treatment, the patient already has metastatic disease. And that's not, at this point, it's no longer curative. You can still treat the patients, but it's extremely rare that everything disappears. But what we can achieve is that the tumors get smaller. And that, as Dr. Calais will talk to you about, works pretty well. What we can also achieve is that the tumor doesn't grow anymore, that we arrest the tumor, prevent it from getting worse. That's called disease control. And then, as Dr. Calais will explain, that can also work with the treatments that we have available. Unfortunately, in some patients, despite the treatment, the disease gets worse, the tumors get bigger, and there are more tumors that appear. So that's where treatment, where imaging is important, because we want to see what's going to happen. When we look at the molecular changes from treatment, we can see that the tumor gets smaller, and usually that concurs with decrease of tracer uptake. The disease can get smaller and still have significant tracer uptake. So not seeing a decrease in tracer uptake, but seeing a decrease in the size of the tumor is still a response to the treatment, good response to the treatment. If we achieve disease control, the disease stays the same size, doesn't get worse. Usually these patients will still have the same amount of tracer uptake. Sometimes the tumors get bigger despite the treatment. They usually retain the tracer uptake, but the treatment unfortunately is not effective. And then sometimes tumors get bigger and they lose their PSMA targets and then have less tracer uptake. So here's an example of a patient that had a baseline scan, as we call it, the first scan before he gets treatment. And this patient got the lutetium PSMA. And this is one of the poster childs of PSMA therapy, because you can see everything disappeared. Again, this is extremely rare, but of course, when we see that is a tremendous success. Okay, so to summarize, what is imaging? It's PSMA that's labeled with gallium-68, or these days also with fluoride-18. It binds the PSMA target that's present on the prostate cancer cells. Why do we do imaging? We do imaging for staging of the disease when we're first diagnosed, and then restaging once treatment has commenced to see whether the treatment is working or not. And then, particular for PSMA, it also helps us identify suitable candidates for the radioligand therapy. When do we usually do imaging? Imaging is usually done for initial staging when the patients are diagnosed, and then restaging during treatment. After a couple of cycles of treatment, you can do a scan to see whether the treatment is working. And then, of course, after treatment, you also want to see whether the treatment has worked, or whether the patient is progressing and needs a different line of therapy. These are the tracers that are now FDA approved. If you remember last year, we're still doing our scanning under research, but now we've done over 4,000 scans here at UCLA. Both tracers are FDA approved now and available at our clinic, and also other sites, I should say. and insurances should cover the costs of the scan. So that's excellent news. Yeah, and that's what I have to say about imaging. Please keep your questions for the end of the talk, and I'll hand it over to Dr. Calais.
Let's say laser pointer. Yeah, that's good. All right. Good evening, everyone. Thank you very much for inviting us again to this very nice patient meeting. It's always a pleasure to share our experience with PSMA Theranostics and PSMA PET-CT related topics. As Martin just talked about imaging, I will focus my talk more on the therapy side. So let's get going and get a brief reminder of what is Theranostics. Theranostics approach. It stands for the combined approach of the use of a therapeutic and a diagnostic agent that both have the exact same molecular target. So it's a targeted approach that use both a therapeutic and a diagnostic agent. So that's why it is called Theranostics. And it's really a way to do what we call individualized medicine, is that you don't treat everyone the same because the disease can be different in different patients with different protein expression, different behavior. And so you really try to treat the patients who are more likely to benefit from a treatment because it's a targeted approach. So you see the target and you treat the target. That's kind of the overall principle of it. Of course, because it is targeted, you're supposed to have less toxicity as well than potentially other treatments that are non-targeted. So here today we talk about a target that is very relevant for prostate cancer, of course, prostate-specific membrane antigen, PSMA. So this target is highly overexpressed by the prostate cancer cells. And as Dr. Auerbach pointed out just before, we have molecules that can bind to it with very high affinity, high specificity, get attached to it. And with the gallium-68 emission, you can do images out of that. You can also bring another radionuclide called lutetium-177 to the same target using the same target. But the lutetium-177 emits different type of radiation than gallium-68. These ones don't go out of the body, so you don't use it for imaging. They stay, on the contrary, on a very limited range where it has been emitted, a couple of millimeters maximum. So it really delivers local radiation therapy with high energy deposition. So you really bring this radiation therapy onto the target with this molecular radiotherapy approach. Here I have this video that I know usually patients like. I hope I'm able to do it. Hold on. No, doesn't work. That's weird. Why? Let me try again. No. All right. So didn't work. Here you can see at least that these treatments are administered by an IV line. So it's really like a drug that you inject via an IV line. So I will skip the video step. Again, I'm really sorry for that. That's weird. Anyway. And there you go. There is the video. So I think if I do share computer sound, yeah.
Specific membrane antigen, or PSMA.
Do you hear a noise? Do you hear the sound?
On the surface of prostate cells.
Okay, so let's do it again. I'm sorry for that. All right.
Yes, we have audio.
When injected into the body, the ligand attaches itself, like a key fitting into a lock, to a protein called prostate-specific membrane antigen, or PSMA for short, which is found on the surface of prostate cells. Up to 1,000 times more PSMA is found on prostate cancer cells, including prostate cancer that has spread to other parts of the body. The second stage of the process is treatment. This involves attaching a different radioactive atom to the ligand and injecting it into the patient's body. This new radioactive atom, lutetium-177, decays more slowly than gallium-68 and gives off a beta particle which kills the cancer. Doctors inject the lutetium ligand combination into the patient's body and it attaches itself to the cancer cells, where it begins to deliver the radiation. The beta particles only travel 1 millimetre, so they deliver high levels of radiation to the cancer cells, killing the cancer.
All right, so it just re-summarized basically with a video and a nice voice what I just said before. You can notice the Australian accent of the speaker because this video comes from our Australian colleagues who were pioneer in this new medical technology. So thanks, credit for them, Professor Hoffman in Melbourne. So just to be sure, we talk about the same thing: PSMA, molecular radiotherapy, radionuclide therapy, radiopharmaceutical therapy, radioligand therapy. It's all the same. It's all these terms denominate the same thing, which you will probably know as lutetium-177 PSMA, at least in the next years only. So now that I've said that, this start to be known for quite some time now. It's been maybe 5, 6, 7 years that some fortunate patients try to travel around the world to get this treatment because until recently, it was very hard to get in the US. So Australia and Germany were the main sites where you could get it for quite some time now. And so there was already a lot of use in the world and traveling around this. This is the way we do it at UCLA. We were one of the 2 first sites in the US to do it. Maybe 3 sites with New York, Houston, and UCLA. We started in 2017 here at UCLA. This is the room we use. We reconverted prior scintigraphy camera room made for imaging for the purpose of therapy. We also treat other patients with other disease than prostate cancer. Some have other cancers for which we also use such molecular radiotherapy techniques. But that's where prostate cancer patients receive PSMA targeted molecular radiotherapy. So patients sit in a chair. It's like more or less like a chemotherapy setting. You sit in a chair, you get an IV line, you get injections, some labs drawn, you have the nurse and the techs around you, and that's how it is done. At the end, it's pretty straightforward. You get a little bit of Zofran for, like any IV drug you receive. You can have some nausea and vomiting feeling. You get a lot of hydration to protect the kidney. And you receive the treatment around maybe 30 minutes of slow infusion with an electronic pump. There is no real other things to do after the injection. We check that the patient feels all right. Go to the bathroom, void a little bit the bladder because a significant part of the non-used treatment will be excreted into the urine by the kidney into the bladder. And so we void that part into the restroom before leaving the site, and then basically discharge home. There is no real protection. You can travel after that. We usually write a letter if you have to take the plane. So it is at the end pretty straightforward, even if it is radioactive. We started in 2017, as I said, and we started with a phase 2 clinical trial that was investigator initiated. At that time, there was no real industry that was behind it. It was a pure academic project. The paper is out now, published last year. This one was about the efficacy, then a second paper more about the safety. This one was pooled with the Houston, so there was a little bit more patience. Then after this first use, and we were really with Houston the first site to do that, Endocyte and Novartis, this pharmaceutical company, acquired the rights for this molecule and initiated a big randomized trial that will be used for FDA approval. This trial is now completed. The data has been matured, has been analyzed and published last year. And this is the data that is still currently being analyzed by the FDA for final approval. In that study, there were 800 patients selected by PSMA PET to potentially receive lutetium PSMA therapy. They were randomized between two arms, a control arm where they did not receive lutetium PSMA, and another intervention arm where they could have received the same hormonal treatment, but in addition, lutetium PSMA. Patients were followed for at least 2 years. And at the end, you can see a clear difference in terms of overall survival. Basically, the blue line that you see here correspond to the patient who receive the treatment lutetium PSMA therapy. So you can see that right away they will live longer, and the same thing all along the time. Here are the PSA response rates. The line that you see here, horizontal in the middle, is the 0. Each, let's say, little line vertical is a patient. When it goes up, like here, it means the PSA is increasing. When it goes down, like here, it means the PSA is decreasing. Here you have a 100% decrease, so it means PSA went to 0. And here you have a clear progression in a patient, for example, that is not responding very well. In the blue, you have the patient who received lutetium PSMA. In yellow, you have the control group. You can see that this part is much bigger in the lutetium PSMA group, which means you have much more patients who experience a PSA response and a PSA decline. On the other hand, in the control group, this part is much bigger here, which means in the control group, you have much more patients progressing by PSA with a PSA increase. So great effectiveness in comparison to a control group. So that's good. This will be used by for FDA approval. And they received, Novartis is conducting that, and they receive what is called the breakthrough designation, which allows them to have a fast track pathway. So the approval is expected somewhere in 2022, very soon. Q1 or Q2 is the date that has been thought to be true, even though for now there is still no news. Until then, between the clinical research use to the clinical standard of care use, there is what we call a mechanism that is called expanded access, and it allows to kind of bridge the gap to get access to a therapy that is supposed to be efficient based on the clinical trial data, still being analyzed by the FDA to be approved. But because we know that there is a great benefit for patients, there is this pathway to bridge the gap and somehow give access to some patients to this therapy because there is a benefit. We, UCLA, participated in that program with the other sites, but we recruited over the period of April to November around 60 patients. Now it is closed because they are switching again to a more commercial and definitive pathway for the use of lutetium PSMA, which I think required them a lot of, let's say, harmonization. So just because of the strategy and just because of feasibility, they closed this program in order to make things smoother on their side to really open on a wide scale when it will be fully approved. But for at least, let's say, 6 months, we were able to offer this therapy to patients who still needed to fit the same criteria than the one that were included into the same Vision big registration trial. So there was kind of a little bit, it's a little bit in between a clinical trial where you still have some some work to do on the inclusion criteria, paperwork, documentation. It's not like pure clinical use, but it's still a little bit flexible. Patient received up to 6 cycles. Many patients are still being treated, currently receiving the subsequent cycle as of now. So this is the kind of the prior history at UCLA and more or less in the US as well in the past 5 years. What can we expect in 2022? Again, I think the approval is really expected pretty soon. I would assume that before June, it will be approved. Some say maybe March, April, I don't know. And this will be run by Novartis still. The indication will be the same that was set up for the VISION trial, which means it's advanced metastatic castration-resistant prostate cancer patients who already failed chemotherapy, so pretty late stage patient and already advanced. They will need to probably get the PSMA PET scan and make sure that on the PSMA PET scan we have enough target expression, and more importantly, no lesions without target expression, because these are the ones that really drive the prognostic of the patient. I think the scheme will be, and the authorization will be given for 6 cycles that can be administered every 6 to 8 weeks. For patients who did not try chemotherapy yet and who are much at earlier stage in their disease course or disease journey, I think it will not be approved right away, but there are many clinical trials trying to establish the efficacy, which is supposed to be greater, because usually these drugs, when they work at late stage like that, the more early you go, the earlier you go, the better it gets, and you get greater efficacy, because the disease is more sensitive to treatments, less resistance, less heterogeneous. So I'm sure it will work well, but as of now, it will be accessible only via clinical trial. I put here some acronyms of the trial. So if you feel you would fit, this will be a trial for you. Here are the name. You have Arrow, Splash, PSMA4, Eclipse. They are all run by biopharma company. And you can check them online, so on clinicaltrial.gov. Probably you will have the slides deck. If you have any questions, you send me an email. I can direct you to the one that I would feel the most appropriate for you. At UCLA, we will open Splash and PSMA addition. PSMA addition is even before castration resistance. It's really at a very early setting, before even patient failed hormonal therapy. So it really gets earlier and earlier. So what can you expect from this therapy if ever you have to do this therapy? Let's talk first about the toxicity. You've seen the images. I will go a little bit of some, whole body images as was shown before again, but you have probably seen some black dots here in along the cheeks. These correspond to the salivary gland. You have a lot of uptake there. And so if you have a lot of uptake on image, it will also, it means also that a lot of treatment will go there, deliver radiation therapy there, and induce some kind of a dry mouth effect, because the salivary gland will take a hit. Pretty common, let's say in 70% of the case. I would not consider it as severe, although I never experienced it myself, but in the clinical trial, let's say language and frame, it's never graded as severe. And so far, I never heard any patient who wanted to stop the therapy because he couldn't tolerate anymore the salivary gland toxicity. So I would call it not severe, but it is frequent. And sometimes it is reversible. Sometimes I feel that even in good responder patients that we follow, they can still describe a little bit of something different compared to before, even months and months after the end of the treatment. As with any drugs that we receive IV, as with any treatment that involves radiation, patient gets fatigue. That's pretty common, and that's a normal treatment. It's just a sign that the body is getting some hits, such as the disease. The dry eyes is the same mechanism than in the salivary glands, so it's a bit more rare than the dry mouth, but patients do have some dry eyes. By the way, I just have a patient who told me that biotin works very well for the dry mouth toxicity. As with any IV drugs, again, many patients can experience nausea and vomiting. Let's say 1/3 of the patient. This is just on the very acute phase, maximum within 2 to 3 days after the administration of the treatment. And it is considered pretty mild in comparison to other treatments for the same disease stage, such as chemotherapy. And you can have some bowel movement disorders, constipation, diarrhea in up to 1/3 of the patients. But at the end, in comparison, again, to other treatments, immunotherapy, chemotherapy, this is considered very well correlated. If a patient had some bone metastasis, the treatment will go to the bone metastasis, which is good. That's what you expect, that's what you want. And it will deliver locally some radiation to this bone metastasis. This can create sometimes what we call a bone pain flare effect. It means it's a transient increase of a painful location. You have a transient increase, which reflects some inflammation, cell killing, edema. Something is happening, some treatment effect. Usually we will treat these symptoms with steroids or anti-inflammatory drugs. And then usually after 1 week, if the response is good, you have a strong decrease of the pain, which indicates a good treatment response. And what we observe very frequently, and that's probably the most important side effect that we can follow, it's the bone marrow toxicity. The bone marrow is in the bone, mostly in the pelvis and in the spine. And if you have some bone metastasis there, the treatment will go to the bone metastasis, irradiate the bone metastasis, but also irradiate the surrounding bone marrow, healthy bone marrow. And it can get a hit depending on the sensitivity of the patient, depending on the load of the disease and the bone marrow reserve. You will have more or less a significant or not a drop in the blood count. Usually what we do, we monitor that closely. Transfusion in very advanced patients can be needed sometime. If we feel that it's not safe yet, we postpone until it recovers to, let's say, a decent threshold before we administer the next cycle. The kidney toxicity has been something of concern initially because you can see very intensively the kidney on the images. But at the end, clinically, we rarely see any toxicity. I think at this level activity, it is pretty safe for the kidney unless you have a prior kidney disease condition or an obstruction or something that makes it more sensitive. But in most of the cases, it's very, very rare. So that's it for the toxicity. So I just disclose it, basically everything that is most commonly reported, but what we have to understand, it is very well correlated in comparison to other non-targeted treatment. The reason is really this targeted approach that spare the normal organs that do not express the target. And with this imaging, you can get more or less an idea of what can be the toxicity. So I can tell you that in the patient in the middle, you may have a good PSA response because there is a great target expression and maybe the PSA is already very high in this patient with very high burden of disease. You will see potentially a PSA drop, but you will also see some bone marrow toxicity. So patients should expect to maybe receive some transfusion from that. In a patient like this one, I do not expect really any significant toxicity. I think it will be pretty well correlated. In a patient like that, depending on where exactly this lesion is located, if it's a rib or scapular lesion, maybe there can be a bone pain flare effect, and the patient can have some pain in the left shoulder. That's something I would say maybe. So you can a little bit guess or try to estimate what can be the toxicity profile based on the image that you get before the treatment. Now, what can we expect in terms of efficacy? So when it works well and you have a very good response profile patient based on the scan like that, you know, these very intense black dots reflecting a very high level of expression. So good radiopharmaceutical delivery on the target with great sensitivity here, complete disappearance of the lesions, and with a great PSA response. You can see in blue is the first PET scan, in blue here the second PET scan, and each yellow arrow indicates a cycle of treatment. And you see a very nice PSA decline. So that's really the story you want to hear. These exist, but unfortunately, it is not the majority of the stories, but it is existing, which has never been seen before. So here again, two examples, a good responder on the left side. You see complete disappearance of the lesion, a very great PSA decrease after 3 cycles. And on the contrary, on the right side, you see a pretty bad response with the increased tumor load and reflected by the images and the PSA. The PSA, you can have all types of response as well. You have some patients that do not respond at all. The curve is continually increasing after 1, 2 cycles, so really they are not benefiting. You have the patient when you see a little bit of effect, you have a flattening of the curve, but it's a bit like up and down. You have some patients that do have a good response initially, but finally after a couple of cycles, they finally progress. And you have patients who respond a little bit late. It takes a little bit, maybe 1 or 2 cycles to get a good response, but then they get a response. And then you have the patient who have directly a great response that you see right away. Of course, some cases are better than others. So that's what I want to say. It doesn't work the same for everyone. And that's something, of course, we're here to give hope, but we don't want to give false expectation. This treatment is not a cure. We have incredible, great stories, but these are stories only. This is not a rule. We have patients who were out of disease for years, but this is really not the majority. We usually assess the response based on the PSA, on the imaging scans, but also on the clinical symptoms. And there will be a study that will be published very soon that show that the treatment lutetium PSMA also delays significantly the pain progression and has a significant impact on the quality of life and the pain. So that's also great. So PSA only, imaging only is not sufficient to assess the response. If the patient is feeling good and feels that he's getting some benefit from the treatment, even if the PSA is progressing or imaging progressing, I would continue to treat the patient. At the end, you have right away 1/3 of patients that do not respond at all. After maybe 2 cycles, you see that it doesn't work for them. In the vast majority of the patients, let's say more than half of them, you have, let's say, a good response or some amount of response with the variable intensity and duration in time. And in maybe 10 to 15% of the case, you have these incredible great responders that usually last for a very long time, pretty impressive. What we do is that we do labs through it before each cycle. And we communicate closely with the treating medical oncologist team to make sure that everything is on board, no transfusion is needed. And that's how we reassess after maybe 2 cycles, we start to monitor if we continue or not. Although there is no real rule yet on how and when to stop. Again, here we can use the baseline imaging to maybe predict a little bit the response profile to the drug. In that case that I showed before, you have very intense uptake. These lesions are clearly black, and there is no, let's say, gray lesion or lesion with low uptake, so patient is responding very well. On the contrary, here you have a lot of lesions, but you can see that they do not look very intense. You even have some lesions in the liver that has absolutely no uptake. And these ones are usually pretty bad. And that's the patient if I see a scan like that, I will tell to the patient, it's probably useless to start this treatment for you. It will not work based on the imaging that is here. There is not enough target expression. As you can see, after 1 cycle, the PSA progress pretty impressively. That's another example of a, let's say, patient with low PSMA expression. You can see all these gray dots here. These are tiny lesions, but they are, even if they are tiny, they do not express a lot of PSMA based on the scan. Here is an example of a PSMA negative lesion, a lesion that is known to be prostate cancer. You see it on the scan, the CT, it is pretty big and there is no uptake there. Another example here in the lung of this PSMA negative lesion, and here in a big lymph node, PSMA negative as well. There is uptake, but it's below or equal to the liver. So this is really what we're going to look for on a baseline PSMA PET scan before doing the treatment. This is really what a patient should not have before starting a treatment, because this is driving the prognostic and will really indicates that the patient probably will not benefit from the treatment. If you want to go a little bit further, we have identified good, very, very good patient profile response. When patients have lymph node disease only, such as here, they do much better than the others. Again, here, different profile of patient based on the baseline images. As a general rule in medical oncology, the higher the tumor volume is, the worse the outcome is, and the less disease to treat there is, the better the outcome is, of course. Now it gets a little bit more complex here. You can see that these 3 patients have high tumor volume, but here you have a clear black and white images, which indicates, again, strong expression of the disease of the target. And here you have only gray, low expression of the target. And here it is heterogeneous. And this correlates, as you can see on these curves, very nicely with the outcome. The one that have high and homogeneous expression, they do pretty well under treatment, whereas the one who have low and homogeneous expression, they do bad. And the one that has heterogeneous expression, they do not do very well as such. So at the end, the eligibility for this treatment are the absence of PSMA negative lesion and have a sufficient uptake that we judge as sufficient when it's above the liver in the majority of the lesion in the patient. Now, if you have a high uptake that is homogeneous and a low volume of tumor that is in the lymph nodes only, usually that's the best response profile we can get. But there is never a 100% rule. That's just things we start to observe now. And I will finish with that, with the systemic therapy response assessment, how we evaluate the response with PSMA PET scan. This is still the debate of multiple research work because it is new, nothing is established, it's not that easy. You have sometimes patients who are responding pretty well, but you have apparition of 1 or 2 new lesions among maybe I don't know, 50 others that decrease. How do you interpret that? So for example, in that patient, you can see that the patient is progressing by PSA, but when you do the PET1 versus PET2 comparison, you see a very pretty good decrease of the lesions overall. But maybe if you look here and there, you have some apparition of new. So at the end, we work pretty hard on that to find and identify the good sign that indicate a good responder and bad, let's say, a progression. The new lesion are really still something that indicates probably not a good response. If you have a new lesion, it is not very good. And the volume of decrease, the more there is a decrease, the better is the response. And the more there is an increase, of course, the worse is the response. And we created a score that we call RECIP. This will be out in a paper this year, and we hope this to be implemented in many centers, many trials to be used for evaluating the response with PSMA PET imaging to therapy. And another last project that we have, and we're working on that as well at UCLA, it is to switch from this setting that I showed before to a much more bigger scale one, where now we have a whole floor to receive up to 8 infusion chairs with a center dedicated for such therapies. And so that's being done. And this was my last slide. This is my thank you slide. Of course, it's a teamwork. Johannes Jernin is the head of nuclear medicine department. There are many other people across multiple divisions and departments. And of course, here I have my dear friend and colleague, Dr. Alan Auerbach, who is also my ski teammate. And that will be the last slide, the mountain.
Well, thank you, Dr. Calais. Dr. Metzger, I turn this over to you. You might, oh, you're muted. Dr. Metzger, you're still muted. Press your space bar down and see if that, there you go.
Okay, sorry about that. You young guys over UCLA don't realize that you're at the forefront of something very big. We appreciate your coming tonight and telling us all this new information and spending your time with us. The question I have is, what besides lutetium is available and being tried? I saw on Jeopardy the other night that lutetium was the highest density, highest melting point element in the periodic table. And I just wonder, how did you pick lutetium as the agent, and what else is coming?
We wish we could take credit for the invention of this, but we did not invent this. There's a lot of research that's been going on for over a decade or longer, where they came up with this. To answer your question, what's coming down the pipeline, are there other radioactive isotopes that we're using? I think Dr. Calais can answer that better than. There are other isotopes that hopefully are even more effective. Maybe you want to elaborate, Jeremy?
Yeah. Yeah, for sure. Nuclear medicine is not that new. In fact, you know, it's an approach that has been initiated maybe in the 50s with iodine-131. And since then, multiple isotopes have been tried. It's a mix of suitable property for medical use and technical feasibility of obtention. And lutetium has been used for maybe the 80s, so it's not that new. It's just that you needed multiple other technology to bring this to the front line like that. So that's for the lutetium-177. Now there are many others potential way to deliver to a cell expressing a target, such as a prostate cancer cell expressing PSMA, to deliver another radionuclide with different physical property. So there are other beta emitting agents. Iodine-131 is one of them. Some people try to do PSMA targeted iodine-131 molecular radiotherapy. But the main new ones that are coming and will be coming are really the alpha emitters. The alpha emission is different than the beta because it is traveling much less from the point where it has been emitted. Beta is about few millimeters. Alpha is about few nanomicrometers, so much less, so much more specific. You have much less off-target effect. And because it is just on this very tiny distance, the amount of energy delivered in this tiny distance is much higher. So you induce much more DNA damage and cell damage. So people are very interested to use alpha emitters instead of beta emitters for PSMA targeted molecular radiotherapy. People are working on that. We are not there yet. When you see the whole let's say, time frame to go from clinical trial to final approval, we talk more or less almost about 1 decade. So before we'll see alpha emitters approved for clinical use, I would not expect that before 2025, 2030, for sure. But it's coming. There is a massive interest from the industry and the academia, of course. It is done in clinical trial in academia in many sites over the world, but there is no big clinical trial run by an industry company that would be needed for an FDA approval as of now.
Yes. Well, thank you very much. My friend Oliver Sartor, who is at the forefront of all this, thinks you're really onto something big. So keep up the good work.
Yes, I know well Oliver Sartor as well.
Yes, you do.
Okay, we'll get on to our questions. Ira wants to know if you'd compare gallium-68 with PYL and other PSMAs.
So as I mentioned in my talk, I think there are several variations of the PSMA tracer out there that all work pretty much the same in terms of sensitivity, specificity, detection rate of prostate cancer cells. So it doesn't matter which one you get, you'll get a good scan.
Okay. Okay. Aaron wants to know, when is staging done? Is it done at diagnosis or later?
So initial staging is done at diagnosis, and it does not always require a PSMA scan. You know, not every prostate cancer is the same. There are high risk, low risk prostate cancers. So depending on what your pathology shows, and usually the MRI initially done shows, your physician will determine whether this cancer has a higher risk for being metastatic, and then you would get a PSMA scan. And then restaging, as we call it, is usually done after treatment, either because there was initially what was intended as curative treatment, and now there's a return PSA, and you want to know what's going on, or restaging after you've initiated a new form of therapy. You want to see whether that therapy is effective or not. So there is initial staging, which is not done in every prostate cancer, and then meaning a PSMA scan is not done in every prostate cancer. And then there is restaging, where PSMA scanning is certainly very useful.
All right. Chuck wants to know, what is the most effective way to deal with a biochemical reoccurrence? Please include treatment and imaging.
So we should, qualify that we are not oncologists, we're not urologists. So there is a whole slew of treatments that are applicable in this situation that we are not experts on. So, but once you have PSA recurrence, you want to know, where is it coming from? And it can come from the prostate bed, or it can come from lymph nodes, or it can come from other places. So in this case, a PSMA scan is helpful because it can tell you whether the recurrence is a local recurrence, which can be treated with radiation, whether the recurrence is oligometastatic, which can be treated with localized treatments, usually radiation, or whether the recurrence is systemic, meaning there are multiple lesions, usually defined as more than 5 throughout the body, that require systemic therapy. First-line systemic therapy is usually what's called androgen deprivation therapy. And then there are additional layers of therapies that urologists are better qualified to comment on. And our PSMA therapies are, down the line, so they're not first line or second line therapies.
Okay, thank you, doctor. Michael wants to know, why is lutetium unable to kill the prostate cancer cells? Is it because not all prostate cancer cells express PSMA, or is it because lutetium isn't toxic enough, or is it something else?
All of the above. There are multiple reasons for that. There are many things we don't know, but for sure the reasons for relapsing under this treatment is either there is not enough target expression. So no target expression, meaning not enough radiopharmaceutical therapy delivery on the site you want to treat. So that's clearly one reason. And then you have the amount of radiopharmaceutical you want there to deliver sufficient dose enough there. And that's another reason. If you don't have enough radioactivity delivered, the cells will not be killed enough. And then you also have the radioresistance. And in radioresistance, you have all kind of mechanism. You have intrinsic radioresistance, acquired radioresistance with mutation cells can evolve and escape some, can evolve and mute and have some mutation to escape the treatment pressure they are under. And so then you have biological complex mechanisms to explain non-response. So it's a combination of all of these. At the end, that's why you have only maybe 10 to 15% of patients who do respond extremely well, and all the others, they are along the way in this spectrum of multiple parameters that make the patient not responding very well. At the end, down the road, you have the patient that has a disease completely not expressing the target, with the cells that are very radio-resistant, a high volume of disease, the treatment will not work. And on the complete other spectrum, you will have a patient with disease that only express the target at very high level and is very sensitive to the effect of radiation. And that's, along that way, you have all kinds of patients with various parameters.
Okay. Let's see here. Joe wants to know, would it make sense to use PSMA PET early in the PCA journey rather than the less effective bone scan and CT scan? Thus, you'd be catching METs earlier.
Yeah, as I answered the question before, not every prostate cancer requires imaging, but once you have a prostate cancer that requires staging, then PSMA is certainly more effective than doing just anatomical imaging, and certainly more effective than a bone scan. So if it is a prostate cancer that requires staging, you should get a PSMA scan.
It is now part of the NCCN guideline, and the guidelines clearly indicate that it can replace bone scan and CT, and can be the upfront first imaging modality to be used.
Okay. Dr. Metzger wants to know, yes, and that is the goal of modernization of treatment options. Did you want to add to that, Doctor?
I agree.
Okay. Let's see what we have here. Larry, Larry Weaver, did you want me to go on with some of these questions about dry mouth, patients who are good responders? How long does the remission last? Did we cover it for you?
I believe that those were covered in his slides. I got a little bit ahead of his lecture. I would appreciate you going back and asking the question about the Medicare reimbursement for gallium scans for this last year. If they have any information on what might be happening at UCLA to give us our out-of-pocket money back.
I can, let me start and then Martin will continue after. Just the dates, Medicare coverage for gallium-68 PSMA 11 has been official since October 2021, and for PYL since January 2022, so very recently. Now, from the announcement of Medicare coverage to actual reimbursement with true money in the bank account of the hospital, there can be a little bit of time difference. But at the end, now for all Medicare patients that come to UCLA to get a PSMA PET scan, they don't pay. They don't pay. They're covered by Medicare. Private insurance can be different. The more and more they are trying to align on the Medicare, and the more and more we expose them to PSMA PET scan, the more they're reimbursed. I still hear quite some stories with patients who get private insurance denial for their PSMA PET scan. So it still happens, but I think within the next 1 or 2 years, it will be less and less. Martin?
Yeah, in terms of getting money back, that's always difficult. We're trying. It's a lengthy process, and I can't make any promises, but we're trying.
I might comment a little bit that I just called up to UCLA and was sent off to billing, and they looked up my records and they sent my material off to another place, what they call escalating, and they're going to get back with me in a few days on the reimbursement. So I've drilled a little bit into the system that might add to your experience.
your experience is as good as my experience. It's a convoluted process, and once you call, it's like trying to get a free airline ticket with your bonus miles. Very frustrating, and all I can recommend is being persistent, and we're trying from our end, but it's, as I said, it's not something that we can decide, so it will take time.
Okay. Larry, anything you want to add? You muted yourself, Larry.
Yeah, okay. I did have a question mentioning the dry mouth and the nausea. And I had 3 cycles, and the dry mouth was getting to be serious, and so was the nausea. And I can't imagine having 6 cycles. I mean, for me, I'd really feel beat up.
Yeah, I have a patient today. He finished his 6th cycle, and he reported that the dry mouth was really start to be really bad, and he was wondering if he should do his 6 cycles or not. And so it was this ratio between benefit and risk. At the end, that's the one who told me that biotin was doing some good on his dry mouth, but. No, I agree. We should not underestimate the toxicity of the drug. I fully agree. I think it's very variable from one patient to another. So we should really listen to the feedback of the patients. Again, this patient, he started to say that it was bad maybe after cycle 4. And then we were like, should we do cycle 5, cycle 6? But he was responding so well that we wanted to maximize the profit of getting the drug. There is no hard rule here. It's a bit the feeling, patient-doctor discussion, but it is not to be underestimated. I fully agree.
Yeah. I tried the biotin, and I tried the toothpaste and the biotin mouthwash. I still use the biotin, and it's been 2 or 3 years now since I was treated.
Mm-hmm.
I have some dry mouth, but I can live with it. But it was pretty bad there for a while.
So, for example, to answer to the prior question about other nucleid, if you use a much more powerful radio emitting agent, such as actinium and an alpha emitter, here the dry mouth effect is really bad. And some patients right away with two cycles with a great anti-tumor effect wanted to stop right away because it was directly very bad on the salivary gland. So that's another thing that kind of preclude a huge, let's say, enthusiasm from the industry to jump onto the actinium PSMA targeted agent, is that so far we have no good way to mitigate this side effect. People are working hard to find a solution, but that's one of the elements as well. And of course, when you're very advanced, late stage, and you don't know how much time you have, how much other treatment option you have, you may be okay to get some dry mouth effect, even if severe. But if you're much earlier in your disease stage and you have years and years in front of you, you maybe don't want to do that. So that's, it's always something to consider.
Okay. Fred wants to know, is there an expected PSA level to qualify for treatment with lutetium-177?
So in the big trial that has been used for the registration, and I'm sure that will be kind of the most commonly used criteria to just follow what has been done in this trial, they use the liver as an organ of reference to say above, equal, or below the liver. At the end, the higher it is, the better it is. It means you have more target expression, more radiopharmaceutical drug delivery at the place you want. The lower it is, the worse it is. It means you didn't have enough target expression. There will be not enough drug delivery there where you want. So that's the basic principle. The liver is used as the reference. What really matters is to have as less as possible lesions that are below the liver. even more than having lesions that are really above the liver. What matters is to not have lesions that are PSMA negative. That's the most important thing, because these are the ones that will progress because they are not receiving enough treatment.
Okay. Back to the salivary glands. Larry wants to know, how is the progress on preventing lutetium absorption in salivary glands? It's an important question.
People tried initially to do a cooling of the salivary gland during the administration. The potential theory behind the idea was to decrease the blood flow in the salivary gland transitory during the uptake time when you are administering the drug, but it didn't work very well, in fact. People tried different thing with the Botox, then people tried couple of things where they tried to, we tried in our study to see if, for example, monosodium glutamate, which is basically something that you have in umami, or that there is an interaction with the glutamate metabolism that is linked to the PSMA molecule. And we try to give that before and in a scan in the same patient, with and without. We do the scan and we see a strong effect. It was given in a very, very high dose that you would never get in any restaurant. And you see a decrease of the uptake in the salivary gland, in the kidney, but also in the tumor lesions. So at the end, it didn't work out as well. So people are trying to work on this. The main approach that is being investigated now in good trials is to use a different carrier, a different binder molecule than PSMA 617, for example. There are other molecules that can bind to PSMA and carry this radioactive atom. And there are some that has kind of different binding properties where they do not bind or less to the salivary gland. And so that's, I think, the most promising approach. It's just that you have to go through the whole validation process with these specific molecules again, validated in clinical trials again, before you can reach availability. But I think in theory, that's the approach that makes more sense to me.
Okay. Is there a sensible PSA level to initiate PSMA scan with a biochemical prostate cancer?
So, there's a correlation between the detection rate, the ability of the scan to pick up some disease, and the PSA levels. So at very low PSA levels, the sensitivity of the scan is limited. A negative scan is not always, useless information, because the assumption is then that the recurrence is in the prostate bed and there's no metastatic disease, and these patients will undergo radiation to the prostate bed, assuming that that's where the recurrence is taking place. But if you have a PSA of less than 0.5, the sensitivity of the scan is very limited, probably below 50%, 40%. Once you get to a PSA level above 1, on the other hand, the sensitivity is pretty good. Goes up to 80, 90%. So with very low PSA levels, you might want to wait, or if a negative scan is helpful for the treatment decision, I still want to go ahead.
Okay. Ira wants to know, is there a Gleason required for Medicare reimbursement?
No, the FDA approval is pretty broad, and there are no limitations whatsoever regarding PSA levels. So.
And no Gleason.
And Gleason, sorry, yeah.
I mean, for the initial staging, they say patient at risk of metastasis. So then you can interpret that the way you want, but they will never ask for any Gleason pathology records.
Okay. Bill wants to know, do you start lutetium-177 treatment with an anti-nausea drug? And there's a broad field of anti-nausea drugs out there.
We have oh, sorry.
No, go, Martin.
Yeah, we have, so our standard procedure is to give a strong anti-nausea medication. And if we see that patients, if that it's not enough for patients, on subsequent cycles, we can give additional anti-nausea medication. We have a pretty good handle on the nausea. It's not rarely a problem.
Outstanding. Final question, Larry. Larry wants to know, explain why lutetium-177 does not work well on bone lesions.
That's a good question. Some people are spending their life on that to answer the question of radiosensitivity of the microenvironment surrounding the tumor lesions. And you're right. Soft tissue lesion, lymph node lesions, they tend to respond better and be more radiosensitive than bone. What is the real answer to that? I think it's, again, a mix of many parameters. But it's related to the microenvironment surrounding the bone lesion. There is one thing, for example, with radium-223, it has been shown that in patients who has lymphopenia with radium-223, they did not get a good response. And in fact, you need also to enhance the effects of the radiation delivered from the esophagus to have a good lymphocyte content, because a lot of the cell killing that will happen will come from the immune reaction that is increased in consequence. So you need to have a good immune microenvironment surrounding. And I think it's less potent in the bone than in the lymph node. Then it's also about just the staging, because it's not about only soft tissue versus bone, because of course, if you have liver, you're still doing worse than if you have bone. So it's also a stage of aggressiveness of the disease. The lymph nodes corresponds in the TNM classification at an earlier stage with better prognostic intrinsically, without even treating with radiation or with any treatment. When you have disease in the lymph node only, in comparison to bone, you do better. And when you have disease in the bone, in comparison to lung, liver, or whatever visceral disease, you do better without even any therapeutic intervention. So it is also the intrinsic prognostic of the disease where it has reached this or this organ, it is at a higher risk or not. And so the bone in comparison to lymph node is worse, but the liver in comparison to bone is also worse. So it's all these parameters mixed together. But at the end, it's true. If you have lymph node disease only, you are likely to do better than if you have a bone and other thing.
Excellent. We're right up against 8:30 right now. I want to thank the doctors and give anybody an opportunity for parting comments.
It was a pleasure presenting to you. You're a highly informed group, and it's always interesting for us to hear your questions because they help us get better.
Yeah.
So thank you for that.
And the
Thank you
feedback.
for joining us. And if you would join us next month this time, when our guest presenter is Dr. Mark Scholes of the Prostate Oncology Specialists in Marina del Rey, California, near LAX, and author of the book Invasion of the Prostate Snatchers. Please, if you're not signed up for emails from us, check out, send us an email to prostateforumoc@gmail.com. Delighted to put you on our mailing list. And I thank you all for attending tonight.
Thank you very much.